But in skeletal cells, they don't do anything. They just stay, لما يجيها impulse, and then it starts contracting. In cardiac cells, sodium channels, they leak for a bit. طيب, leakage of sodium channels هو اللي يرفع يعني هو اللي يزود transmembrane potential. It makes it more positive لما تجي until it reaches the threshold and that starts to fire. عشان كذا cardiac cells has a potential to generate impulse even on its own. The skeletal muscles do not. But this is just a general idea about the idea behind the impulse.
حابة تحطي المايك دكتورة خديجة معك؟
صوتي مشكلة. Okay.
لا ما حيوصل المايك.
هو شغال.
Okay. طيب. So the channels responsible for every stage زي ما كنا درسناها في physiology is usually three main ones. So stage 0, it's sodium channels. The plateau phase, stage 2 is calcium channels. Or stage 3 is potassium. But it's actually much more complicated than that. So these are the actual channels that work in every stage of the heart. You don't need to know them all unless you want to do electrophysiology. But overall, it's still the same thing. Here, sodium is more predominant. وبعد كده calcium في plateau phase والpotassium في depolarization with sodium influx in pacemaker cells اللي هي cardiac cells. But you still have a lot of other channels. فمثلا just before stage 2 اللي هو stage 1 you have potassium, calcium. There's 2 sodium channels that work in stage 0. There's more a total 4 of potassium cells. So anyway, and any mutation in each of those gives you a disease. So a mutation in IKS1, for example, gives you a certain type of long QT. IKR gives you another type of long QT syndrome. So any mutation in either of those can cause you abnormalities of repolarization. But what you need to know is this. So these are the main sodium, channels that work. So sodium phase 1, calcium phase 2, potassium phase 3. وبعدين اللي هي sodium influx for the pacemaker cell. So this is basically what you need to know. So this is what I was talking about. The automaticity in the cardiac cells is caused by the sodium channel leakage in stage 4. This allows the muscle to continue to regenerate the impulse over and over again. How fast it regenerates the impulse depending on that differs depending on what kind of cells you have. So مثلا sinus node, they generate the impulse fast. They have the highest rate in the heart and they are the predominant pacemakers. Like other atrial cells are slower than that. فمثلا if the sinus rate 120, the other atrial cells are 100. If the sinus node fails, the other atrial cells اللي هي شوية أبطأ منها will take over. The AV node is even more slower, while ventricular even more slower. واللي يخلي sinus nodes faster than مثلا ventricular myocardium is the degree of sodium channel leakage. Here we have faster leakage فيوصل الثريشولد أسرع فيصير الإمبulse يجي أسرع وأسرع. إذا leakage is very slower, it takes time until it reaches the threshold وبعد كذا it fires. تمام. لكن كلها في الأخير has the ability to generate its own impulse. عكس تماما الskeletal muscles or other cells. If لو في مشكلة in the cell itself or they have increased leakage of the channel of the sodium channels, هذه يخليها عندها enhanced automaticity. وهذا السبب في اسمه automatic arrhythmias زي junctional tachycardia, atrial tachycardia. They were normal myocardial cells ولهم their normal automaticity لكن it became enhanced. طيب لدرجة إنه صارت أسرع من sinus node, so it took over. تمام. وهذا يديك فكرة what can we do to treat it. So if you block the sodium channels, you will block that abnormal impulse. I'm going to skip that because this is a little bit more detail. So mechanism of arrhythmias is basically 3 mechanisms. Here basically 2, with ثالث is a combination of both. So either you have the first mechanism is automaticity, which means they're just increasing the number of generation of the impulse, or you have re-entry, or a combination of both in a triggered activity. Okay. So let's talk about the differentiation between either of them. Automaticity, it's like the same thing that we explained. A group of cells that are more active than they should normally be. And that group of cells can be anywhere. They can be the atrium, ventricle, the AV node, and anywhere. So if it was an atrium, they will give you atrial ectopic tachycardia. إذا هو in the AV node itself هتكون junctional ectopic tachycardia. If it's in the ventricle, it'll give you ventricular tachycardia. And sometimes even the sinus node can be inappropriately active. هتلاقي المريض مثلا he's sleeping where sinus rate is 120 or 110. This is called inappropriate sinus tachycardia. This is predominantly an adult disease and like an adulthood disease, but it can happen sometimes in children. So this is the first mechanism. It's quite simple. You have a group of cells that are more active than they should be, and that's called automaticity. The other mechanism of arrhythmias is re-entry. And re-entry definition means that an activation wavefront propagates around an anatomical or functional obstacle, and then it comes back and reactivates the same area that it started from. Okay, so this is re-entry. Re-entry لها requirement, and مو أي أحد يجي له re-entry. So, for example, you don't have re-entry, but the patient in the ICU has re-entry. So why does he have it and you don't? فكل re-entry circuit لها requirement. Okay, so let's start مثلا إذا I have a normal heart, normal myocardium, ما في scars, ما في أي شيء. The signal will go from the beginning of the muscle to the end. There's no chance for re-entry to happen. Okay, so to have re-entry, number one, you need to have something in the middle that does not conduct electricity عشان حوالينه تصير re-entry. Okay, so you need to have a central obstacle, and this can be a valve, can be a scar, can be a patch, can be a device, anything that will not conduct electricity. Okay, طيب, so let's say I have this is a myocardium, healthy myocardium, all conducting in the same speed. وفي النص I have an obstacle, either anatomical or functional obstacle. What will happen is the signal will start in one area, and then it propagates لما ترجع, and by the time it comes back, the area that it started in is still depolarizing, so it will just die and it cannot reactivate it. فهنا برضه ما يصير عندنا re-entry. So having just the functional obstacle في النص is not enough. What I need, I have two different conduction velocities, one fast, one slow, بحيث لما السيجنال يوصل يرجع هناك, it's still able to, يعني it has recovered and it's able to activate it. تمام؟ هذه أهم نقطة في re-entry. Is that clear? تمام؟ فأنا أحتاج an obstacle in the middle. I need two different velocities. واحدة fast, واحدة slow, بحيث إنه إلين ما يوصل السيجنال I'm able to maintain the re-entry circuit. فيبدأ fast, slow. تمام؟ وهذا ينطبق على كل re-entry circuits. فهذا two requirement, two zones with different conduction velocities around a region of no conduction. Okay? طيب, فخلينا نفكر زي إيش شو اسمه هذا requirements موجودة. فمثلا في حالات ال AVRT, atrioventricular reciprocating tachycardia, عندي ال AV node وعندي accessory pathway. Okay, so the accessory pathway, وبعد كذا عندي هنا ال atrial tissue وال ventricular tissue. فال accessory pathway is my fast limb, ال AV node is my slow limb, وهذول الاثنين is a part of the circuit. طيب, وال functional obstacle, it's a functional one and it's just the cavity inside the heart. فهنا بصير re-entry circuit. Okay. إذا أخذنا AV node re-entrant tachycardia, a re-entry circuit is inside the AV node. The AV node عندي two pathways, one fast and one slow. تمام. وال circuit is in between those two. Okay. ولازم يكون with a certain appropriate conduction velocity. لأنه إذا كانت مثلا اثنين are relatively fast, you will not have re-entry. عشان كده 30% من الناس عندهم dual AV node pathways, بس مو كلهم عندهم AVNRT, مرة أقل من كذا اللي عندهم AVNRT. Okay, so you need to have an appropriate. أو مثلا في ناس they don't have SVT at baseline, but when they have fever they have SVT ومن غيره ما في. أو they only develop SVT when they have exercise. لأنه لازم two velocity to be really appropriate for the re-entry to happen. البيشنتس اللي يكون عندهم مثلا tetralogy repair يكون عندهم scars. So this الscar هي في النص هي region of no conduction. ولازم برضو I have a slow region, لأنه لو بس عندي scar في النص وباقي المايوكارديوم healthy ما حيصير re-entry. Okay, عشان كده مو كل التترالوجيز عندهم VT. لكن إذا البيشنت عنده scar وعنده area that has some dead cells or some يعني اسمه healthy cells, so that when the signal goes in لازم يشوف له طريق بين ال healthy cells وال dead cells, so it will conduct slowly وبعد كذا يرجع fast. هذه حتكون عندك good situation for re-entry to happen. عشان كذا not every person has it. الاتريال فلوتر نفس الشيء. الري-entry في الاتريال فلوتر بتكون around the tricuspid valve annulus. تمام. هذا في الكلاسيك اتريال فلوتر. والزون اوف سلو كوندكشن حيكون in the very tiny area بين tricuspid valve annulus وبين the IVC. نسميه cavo tricuspid isthmus. Okay, because it's a very slow area. وهنا في venous tissue وهنا في AV valve tissue that's fibrous, فالconduction بيكون فيها slow. تمام. So when we want to ablate, we usually try to ablate يعني the narrowest area possible. So we try to ablate the slow conducting area. And then AV and RT, we ablate the slow pathway. في atrial flutter, we do cavo tricuspid isthmus ablation. فنحط ablation line هنا. Okay. في السكار نحاول نوصل المنطقة هذه والمنطقة هذه. So we will cross this slow conducting zone فنحط ablation line زي كذا. So this is where you target the therapy في حالات الري-entry. Okay, so this is an example نفس الشيء اللي قلنا عليه. So atrioventricular reciprocating tachycardia بالنوعين اللي حنعرفها depending on whether it's going down the AV node ولا up the AV node. فال AV node هو الفوكس. Antidromic يعني عكس ال AV node. Orthodromic مع ال AV node. So orthodromic down the AV node up the pathway. Antidromic is down the pathway up the AV node لأنه هذا العكس الطريقة العكسية. Orthodromic يديك narrow complex, antidromic يديك wide complex. AV and RT هي هذا قلنا so we have two pathways, a slow pathway or fast pathway. وبعدين depending on which one is up and which one is down or which one is antegrade, which one is retrograde يكون classification حقتها. So classically the signal if it goes down the slow pathway or fast pathway and up the fast pathway هذه typical AV and RT. تمام. فكيف بيكون شكلها؟ So we're going down the slow pathway from an atrium, the ventricle slow pathway فيجينا QRS. Okay. And then the signal goes back up through the fast pathway. So it goes up لأنه طالع بالfast pathway is conducting really fast. تمام. فالP wave اللي تيجي بعدها حتكون مرة قريبة من ال QRS بحيث غالبا تكون inside it. Okay. So slow وبعدين fast to the atrium. Slow fast to the atrium. إذا هو بالعكس تمام. Signal is going down the fast up the slow. So it goes down the fast يجي QRS وبعد كده up to the slow it takes a long time إلى ما السيجنال يرجع للأتريوم. So you would have a long VA interval. وبعد كده QRS تمام. بعدين up the slow. So هذه نسميها atypical fast slow. وهذه رير تقريبا 10% من ال AV and RT is atypical. أغلبهم بيكون typical slow fast. Okay. طبعا. Absolutely. No, go ahead.
بس بالاي سي جي can you say one more time كيف نفرق بين التيبيكال والاتيبيكال كيف الشكل؟ لان انا يعني ما قدرت القصه معك. Sure.
So duration بين ال QRS وال P wave اللي نسميها RP interval. RP interval. وهذا يعتمد retrograde limb is which pathway of it. عندنا two pathways slow fast. Classically it's down the slow up the fast. Okay. فالsignal نزل من ال atrium لل ventricle by the slow pathway. هدينا QRS عادي زي أي قلنا نازل وبعد كده it goes up the fast pathway فبسرعة بيجينا الاتريال signal لدرجة إنه أحيانا في أغلب الأحيان الاتريال signal is actually very close يعني هنا أو actually it's inside the QRS. For typical AV and RT we don't usually see P waves لأنه actually it's inside the QRS لأنه طالعة with a very fast conduction. تمام. لكن لو إنه العكس لو إنه fast slow يعني نازل fast وطالع بالslow لما ينزل بالfast يدينا QRS عادي وبعد كذا يطلع بالslow pathway so it takes a long time للsignal لما يوصل الاتريوم. تمام. فيدينا long RP interval. فتشوف ال P waves وتشوفها negative وبعيدة عن شو اسمه عن ال R wave. Okay. Atrial flutter, as we said, is a re-entering circuit around the tricuspid valve, and this is our slow zone conducting velocity. ليش الفلتر بيكون شكلهم زي كذا؟ لأنه زي ما قلنا re-entering circuit is around the tricuspid valve. تمام. So let's say we are recording from lead 2, from the foot. Okay, the signal will be coming towards the foot. Okay, فهذا حيدينا positive signal, and then it doesn't stop. It just keeps on going and goes away from the foot. فهذا حيدينا negative, and then it comes back again. So positive, negative, positive, negative. ولأنه re-entering circuit, it doesn't stop. فما في isoelectric line. Okay, so it'll be just going to be like sawtooth pattern. It just comes and goes and comes and goes. وبناء على the direction, we can know which type is it. Is it typical? فحتى الفلتر في typical و atypical. يعني we don't really have to go into the بس إنه anti-clockwise is typical or counter-clockwise atypical. It doesn't matter in terms of treatment, but it's just for classification. فلو المريض has a normal tricuspid valve, normal atrial size, structure, normal heart, هذا الفلتر اللي يجيله. Okay, abnormal heart, mechanical valve, fontan, it's not going to be the same shape. هنتكلم عنه بعدين إن شاء الله. Re-entrant ventricular rhythms. فلو لاحظتوا دحين الفي تي في نوعين، في اوتوماتيك في تي وهي يمكن الوحيده اللي كذا، في اوتوماتيك في تي وفي ري انترنت في تي. طيب depending how they behave. فاغلب اللي احنا بنشوفه بيكون scar related في تي، so you have a scar, you have a zone of slow conduction ولا شو اسمه السيركت بتكون هذا. او in patient with structurally normal heart, especially adolescent، في نوع من الفي تي ري انترنت بيكون fascicular في تي، فانه السيركت يطلع من نهايه الفاسيكل وبعد كذا يرجع للمايوكارديوم يدخل inside the fascicle. This is something you need to know for fellows. حاجة يسموه idiopathic left ventricular VT أو بالhasten tachycardia وهذا بيكون sensitive to verapamil. It's just a specific sort, and it's very benign. One of the benign childhood VTs. يعني يمكن بيكون 10% of all VTs. It's not very common, but it's very specific. It's important to know لأنه it's benign, so you can reassure the family. And ablation is very successful in these cases.
هل الريسك of developing arrhythmia around the scar or valve or whatever in relation with the period post-operatively? يعني recent is more risk than all the operation?
Most of the post-operative arrhythmias are automatic. لأنه it takes time for the scar of fibrosis to happen. فpost operative غالبا بتكون automatic مثلا jet أو atrial tachycardia أو كذا. It takes time until the scar is established وال zone of slow conduction is established. فنادر ما نشوف re-entrant just after surgery. تمام. فغالبا بيكون بعدها how much time I don't know. بس يعني شهور لسنين يعني.
Yeah, it's standing risk all through. Yeah, it won't be eliminated by time. Yeah, مثلا بعد
eliminated by time? No, it can actually get worse by time.
Okay.
Yeah, لأنه they will develop more volume load, more ischemia, more scars, so they're more likely to develop it later on than early on.
Simple basically patch closure ممكن مثلا بعد 5-6 سنوات.
Yes. أيوة. وهذا main cause of one of the important cause of mortality في الVT في التترولوجي اللي هو late onset arrhythmias يعني أو يعني even in all adult congenital heart disease, not just pathology. Okay, so in repaired congenital heart disease, it's a total different story because you have multiple mechanisms. In congenital heart disease, you have scars, you have patches, you have the hemodynamic effects. وهذا هنتكلم عنه. So re-entry, specifically for repaired congenital heart disease, in the atrium, it can occur actually anywhere around a ASD patch, around the atriotomy scar اللي هي معظم أصلاً cardiac surgery. It occurs with an atriotomy scar. فهذا تلاقيها in any kind of surgery with atrial dilatation or distension. There's predisposition to fibrosis, so that can form multiple circuits. So you might not see, you will see flutter commonly, and it will not be the common type of flutter. So it depends on what kind of circuit you have. And then post-ventriculotomy, you will have multiple areas of narrow areas of slow conduction. مثلا في التترولوجي repair, you will have 3 classic isthmuses that arrhythmias can occur around. Either بين الRV incision والpulmonary artery, so this is an area of slow conduction هتصير بين الventriculotomy والtricuspid valve, inside between the RVOT patch or VSD patch والtricuspid valve. هذا 3 classic areas where you can have slow conduction and VT can occur around this. So when you want to take a patient with tetralogy to the lab, you need to look for this area وتشوف مين فيها are the cause of this arrhythmias. But this is classically for tetralogy, and it's the most common, so it's the most studies. Like, and it can happen with anything. For example, truncus repair or patients post-sano, because they usually have a ventriculotomy at the same time. But these are all potential areas of re-entry. And you can imagine how much re-entry you will have in a mustard patient or a Senning. You imagine how long the suture line is and how the circuit can go around those suture lines. They usually have really incessant and difficult to treat flutters. So this is just to give you an idea, these patients have more substrate of arrhythmias. غير substrate of arrhythmias, they have multiple causes for it. So either preoperative or post-operative, they have multiple causes of both atrial, both tachyarrhythmias or bradyarrhythmias. So preoperative and the sinus node itself can be abnormal. If you have left isomerism, they may have absent sinus nodes, or in juxtaposition of the atrial appendages, they can have an absent sinus node. The effect of valvular regurgitation and valvular stenosis. So we have pressure and volume, load, كل هذا can predispose to arrhythmias, abnormal AV node, because if you have abnormal anatomy, for example, CCTGA, or AV canal, abnormal coronary arteries, these can lead to ischemia and scar formation. هذه كلها before the operation. And then after the operation, the presence of scars, patches, AV node injury, coronary artery injury, and the long-term effect of volume pressure load again. So you have really a lot of causes of arrhythmias and congenital heart disease. I think that they usually have more than patients with structurally normal heart. And then perioperatively, patients on medications, electrolyte imbalance, repolarization abnormalities. So this kind of summarizes the causes of arrhythmias and congenital heart disease, and there's really a lot. So these are the two mechanisms. Okay, أنا أتكلم يعني كثير, but these are the two main mechanisms, automaticity and re-entry. So the main differentiation between them both, in automaticity, they usually, you just have a focus that just keeps on firing. So it will behave زي a normal rhythm. So it has a gradual, أو يسموه warm-up, a gradual start, and a gradual slow down. والrate in between is variable. Okay, it's not a fixed circuit, it's just a focus that just keeps firing. فمثلا if the patient is crying, it will fire more, لأنه you have more sympathetic drive. If the patient is sleeping, it will fire less. إذا عندك electrolyte imbalance, it will happen. إذا في foreign body مثلا line في atrium, it will be more triggered. So it has a gradual onset, gradual termination, or variable rate, and cardioversion doesn't affect it. So if you pace the part of the heart or defibrillate it, it will not stop. Okay? A re-entry عكسه. It has an abrupt onset, abrupt termination, and the rate is usually steady. لأنه you have one circuit, مساحة الcircuit is the same, في الduration اللي تأخذها عشان تكمل الcircuit is the same, so you have a very fixed R2R. Even if you take it by calibers, usually the R2R is exactly the same thing. So if you look at the telemetry, فمثلا the nurse قالت لك this patient had a heart rate of 200 at night, and you want to kind of get an idea about what kind of rhythm he has. So if you see this kind of trend, gradual onset, وبعد كده the rate here is not really fixed, but in gradual termination, this is an automatic focus. ممكن يكون sinus, وممكن يكون arrhythmia. It depends. Like if it was like this, an abrupt start, fairly fixed rate, abrupt termination, شكله زي البوكس كده, this is a re-entrant circuit. Okay, so these are the things. These are the main things that differentiate an automatic focus and a re-entrant focus. And it's important لأنه له علاقة بالtreatment. So you can مثلا cardiovert a re-entrant focus, but you will not cardiovert an automatic focus. And you cannot overdrive pace it. You cannot do anything of that. So هذه يمكن أهم slide في المحاضرة كلها. واضحة? Okay. And then triggered activity is the same. So it has the same kind of onset like automatic focuses, but while the patient is in arrhythmia, it behaves like a re-entrant one, so you can cardiovert it to defibrillate it. But the way it starts and ends, the way it triggered, زي automatic focus. And there's only two examples of triggered activity: torsade de poids and long QT, and digoxin toxicity. So هذه الاثنين are the only two يعني the main two examples of trigger activity, so it's not that common anyway. طيب, so this summarizes mechanism of arrhythmias. Any questions? Do you want me to repeat anything? أنا عارفة أنا أتكلم بسرعة.
Last one, automaticity. examples حاجاتهم اللي هو.
Triggered activity اللي هي combination of both.
Okay.
Yeah, فهذا combination of both اللي اسمها triggered activity اللي هو third mechanism of arrhythmias, digoxin toxicity and long QT. Arrhythmias and long QT. دكتور سعد.
ساعات بلاقي برضه على فيكسد ريت يعني ساعات حالات بلاقي
sometimes but usually it's variable يعني لو أخذت اسمه episode من أول ما بدأت إلى ما انتهت it's not one heart rate, it can be a little bit variable. لكن if you take
lower side شوية اللي مثلا say مثلا 180 مثلا most of the time around 180
around, لكن بتلاقي مثلا 175 180 182 100 يعني variable. أي
220 180 يعني مفيش زي الهولتر ده يعني الهولتر اللي أنا شايفه ده في significant variation في الهارت ريت.
Yes, فهذا كلاسيك.
التاكيكارديا بلاقيها يعني almost كأنها straight line يعني.
If you take an ECG يمكن أن يكون slow snapshot of the time. لكن if you look at the telemetry you won't see it like this. ما حتلاقيه abrupt كأنه خط واحد. أيوة yeah. لكن if you do an ECG يمكن تلاحظ إنه لأنه the ECG is like just a 6-second snapshot of time. It can be fairly fixed then. وكثير من الأحيان if you will only pick it up if you do a long rhythm strip فساعتها تشوف variability في heart rate between the R to R. نمشي اللي بعده. Okay, antiarrhythmic therapies. So it's classified according to which channel it blocks, so the action of the antiarrhythmics, and the classification to classes based on Vaughan Williams classification. It's classically 4, بس في ناس أضافوا a fifth class وحطوا فيه كل اللي ما هو في الأول. So class number 1 is sodium channel blocker. Okay, class 2 is beta blockers. Class 3 is potassium channel blockers. Class 4 is calcium channel blockers. 5, they actually add in it everything, digoxin, atropine, adenosine, كله يعني it's all added in class 5. So let's take it one by one. So sorry, it's a bit of a busy slide, but this kind of summarizes كل شيء about the sodium channel blockers. Okay, so sodium channel blockers, what it does is that it slows the conduction in phase 0. Where actually the sodium channel works. So when the conduction is slower, the slope is not going to be sharp, it's going to be slower, kind of a more declined slope. فهذا action of sodium channel blocks. So when it blocks the sodium channels, the rate of activation and firing will be slower. Okay. The nice thing about sodium channel blockers, and they tend to target abnormal cells or myocardial cells more than pacemaker cells, more than the مثلا sinus node or AV node. You will not see a lot of bradycardia with it. مثلا إذا المريض اديته beta blockers, it will slow everything down. So if you give him sodium channel blockers, you're actually targeting more the abnormal cells or the pathways or whatever. It's used for a lot of primary arrhythmia, so atrial ectopic tachycardia, junctional ectopic tachycardia, VT, and even patient with PVCs. But then re-entry, especially AVRT, خاصة الناس اللي عندهم accessory pathway يعني زي WPD or integrated accessory pathway, it's really helpful. طيب, so if I'm blocking sodium channels, what do I see on ECG? If I'm blocking sodium channels, what do I see? White QRS. لأنه QRS هو الجزء اللي represents the acute depolarization. So if I make the depolarization stage longer, the slope is more declined, the QRS becomes widened. So هذول patients, when we do an ECG to monitor for toxicity, we're looking for QRS widening. Either QRS, تسوي baseline ECG تشوف كيف الQRS interval وبعد ما تبدأ يعني until the medication reaches just steady state. مثلا flecainide 5 doses إلى ما توصل 5 half-lives of it. So you do ECGs until you reach after the 5th dose, معناته it will be steady. If the QRS interval was more than 25% of baseline, then you need to back off. Either stop it or change or get a dose or do whatever you need to do. You need to avoid it. It's contraindicated في الناس اللي أصلاً عندهم sodium channel mutation زي البروغادا syndrome. So if you give it to Brugada patients, they can become realistic. You can trigger arrhythmia. Well, actually, we use this information to trigger the ECG manifestation of Brugada. And the Brugada ECG pattern ما يكون موجود في كل الناس all the time. فمثلا نديهم procainamide infusion. So we see the ECG changes بعد كده نوقف. So this is atrial. يعني can work for atrial arrhythmias or ventricular arrhythmias. Procainamide mainly atrial. Class 2B lidocaine and mexiletine الاثنين بس ventricular. Class 1C flecainide both atrium and ventricle وبروبافينون mainly atrium. طبعا most common من ده كله يمكن lidocaine و flecainide if you want to know it. Any questions about sodium channel blockers?
Class B?
Yeah. But I'm not sure anyone ever uses it as an antiarrhythmic بس يعني it's there.
في advantage مثلا المكسلتين over مثلا الفليكانايد ولا هم نفس يعني
For ventricular?
أنا عندي الاثنين مثلا مكسلتين وفليكانايد.
For VT لا mexiletine. It's more specific. بس مثلا atrial flecainide is better. It's the only one that works. طيب beta blockers. So what beta blockers does, it just slows the rise of action potential all over the heart. That affects sinus nodes, AV node, slows down the heart rate, and it affects ectopic focuses. So it kind of slows down everything. It also blocks adrenergic receptors, or slow down conduction in general for both any normal cells or abnormal cells. If you want to monitor for toxicity, you monitor the heart rate. Too much bradycardia, you may want to back up on those. So you want to see some bradycardia. مثلا إذا في neonate عنده SVT وبدأت على بروبرانول والناس كلمتك أن الheart rate is 100 ولا 90, that's fine because that means the patient is on propranolol and the dose is effective as long as he's stable. So if the patient is stable, no affecting hemodynamics, just leave him. It's okay. It's not a problem. Profound bradycardia means you need to back off the dose or try something different. So it really works as a first-line therapy for everything. If you notice, we started for almost all the patients. Regular paroxysmal SVT, AVRT or AVNRT, atrial tachycardia, ما junction اللي حصل post-operative doesn't really work well. VT, ventricular arrhythmias, inhibited channelopathy, زي CPVT or long QT is very effective. Okay, so really, if you put it anywhere, ما عدا post-operative jet, it will work. حتى post-operative jet, it can reduce the rate. So تحط أي مكان, it actually works. It's right. Potassium channel blockers, they work in stage 3 in the repolarization, so it will prolong the action potential. فإيش حتشوف في الECG?
Prolong
QT interval, okay? QT interval prolongation. So when you want to monitor for toxicity, you monitor the QT interval. ونفس الشيء زي sodium channel blockers. You need to monitor ECG until the drug reaches the steady states, usually within 5 half-lives. And you do daily ECGs. If the QT is prolonged more than 25% of baseline, you need to back off the dose. Okay? It's actually very effective in most most types of arrhythmia, so automatic foci, reentrant, SVT, VT, patients with atrial fibrillation, and sometimes high-risk WPW. Examples is 2 mainly, amiodarone and sotalol. Okay, they both work for both atrial and ventricular arrhythmias. You need to know all the side effects of amiodarone, the acute and the chronic, and they're both pro-arrhythmic. So بسبب QT prolongation. Any questions on potassium channel blockers? Okay. So classes 4 and 5 do not affect the action potential per se. تمام. So class 4 اللي هو calcium channel blockers, they block the L-type calcium channels that work in the plateau phase, and it usually slows the conduction and reduces the rate, mainly in pacemaker cells. So it's not very effective for other cells or مثلا accessory pathways or automatic foci, لكن it blocks the conduction في الsinus node وال AV node. For example, إذا المريض عنده AV and RT, it's very helpful. إذا البيشنت عنده مثلا atrial flutter and you don't want to convert him, you just want to slow down the rate, it's very helpful. But it will not convert the abnormal rhythm. It just slows down the rate. Okay, so this is kind of examples of like a general view of the classes and which arrhythmia is classically used, and the names of the medication in each class. What better is that, so we'll go through this. If you have a patient who has an abnormal sinus rate, so for example, inappropriate sinus tachycardia, not regular sinus tachycardia اللي بتكون secondary, like inappropriate sinus tachycardia where the sinus rate is high من غير ما يكون في أي reason or causing symptoms. So what you can do is beta blockers or calcium channel blockers. They're both benign, and you don't really have to go to the big guns to treat it. You can just use those two. Atrial flutter or atrial fibrillation, depending what you want to do. Okay, if you want to get just rate control, so you use what?
2 plus 2, maybe plus A.
2 وإيش؟
Plus A.
No. If you only want rate control. You just want to slow down the rate. You don't want to convert the rhythm.
Class 2.
Yeah, so beta blockers and?
Class 1A.
No. Calcium channel blocker, yeah, class 4. If you want to convert it to sinus, تبغى rhythm control, طيب, then class usually 1C أو 3. تمام, فمثلا flecainide or amiodarone, flecainide, sotalol, any one of those. Okay. SVT, AVRT, AVNRT, you can actually use anything. You can use beta blockers, you can use calcium channel blockers that can nodal, or class 1C or class 3. لو تلاحظوا كأنها mainly 2-3, either beta blockers or calcium channel blockers for rate, or class 1C and class 3 for rhythm control. Ventricular tachycardia, beta blockers, or class 3. تمام. class 1 أحيانا مو دائما. بعدين PVCs هذا ما نحتاج نتكلم عنه. It's important when you use multiple antiarrhythmics to be aware of the interaction between them. Okay, but it makes sense, and you try not to use, or you actually don't use agents from the same class. فما تستخدم يودرون مع سوتولول مثلا، ما تستخدم flecainide مع propafenone. You try to use different mechanisms to target the arrhythmias from different sources. And then sometimes the interaction between the classes. The most famous one of those is amiodarone and digoxin. So they both kind of inhibit the metabolism of each other. فلو بدأت amiodarone لمريض أصلاً هو على digoxin, it will raise the digoxin level. It can cause toxicity. So whenever you start amiodarone and digoxin, or you want to add amiodarone to a patient on digoxin, you need to cut the digoxin dose to half. Okay. Bagel interaction doesn't necessitate that you need to change the dose, but you just need to be aware of the side effects. فمثلا between flecainide and amiodarone, you need to just monitor the ECG closely, تأكد إنه there's no increasing in toxicity. Flecainide and quinidine and sotalol, and beta blockers or calcium channel blockers, they compete to lowering heart rate and blood pressure, so you need to be very careful if you actually put the patient on both, which you would not. I think this is the last slide. Yeah. Any questions? Mainly because of availability, so it's not that available. يعني وفي sometimes antiarrhythmics that are not actually within this classification. So there's a special kind of مثلا sodium channel blocker, ivabradine. It's not really in animals classification. في newer medications that are ما تتبع بس في يعني the classification.